Have any of your colleagues in cardiology that maybe aren't invasive cardiologists, was there any pushback or resistance to regionalized systems of care for acute STEMI, or were there any political barriers that needed to be overcome?
All of those things are true. Medicine is a complex business, to be sure. There are the people who are worried about change. Change is always difficult. Change will be there, though. It's not the strongest that survive, it's the people that are most able to adapt to changes. And these changes will affect everyone. What we refer to sometimes as the critical access hospital, or the small hospital trying to manage these difficult patients, have a very difficult job because they're on the ground. It's much easier for us at the tertiary centers to say, or look down our noses, that if they would have just done this or they just would have done that. But it's a very difficult job to be there. You have the economic issues that have to be addressed. You have all the way from the CEOs to the people in the community at the cafes, to the nursing staff, to the paramedical staff. You affect a lot of lives when you try to change the way that things are already, hopefully for the better. At the end of the day, the thing that clears the decks for the economic issues, the personal issues, the ego issues, is what is in the best interest of the patient. And as long as you use that as your primary paradigm, it's very difficult to go astray from what the right road is. It allows many patients to be able to be managed at home with some help and expertise from us over the internet. We have electronic stethoscopes, we have digital x-ray, we have digital laboratory, and all of that information can be available to us at a computer, at a PC in the room. We can see all of their data, listen to their heart, listen to their lungs. Now, it's not as good, and nothing will ever replace the physician being there, but these assets, if they're leveraged in what we refer to as the EICU now, because we have these, I think we have some 120 beds that we have fully access with digital information to look at their hemodynamics. We have a webcam, we can look at the patient, we can look at their vent settings, we can look at their laboratory studies and their x-rays, all the radiologic studies. We can converse with nurses in the room. We have electronic stethoscopes for the EICU, and we also have the same access in the ER. So a mid-level nurse practitioner, a physician's assistant, a family practice, internal medicine, ER doc will have access to just about anyone else in the healthcare system. In cardiology, we've been trying to lead the charge to get access to all of that. And what I envision that we'll have a war room where we will have the EICU, the EER, and eConsult all available to us in addition to these telemed CGs. So we will functionally just about be able to digitally be right there. And then when you add Twitter and Facebook and all these other things, if we leverage all of those to the advantage, we'll have enormous resources for delivering expertise to where it's needed.